the opportunity to visit Finland and to be able to see the Aurora Borealis. And so as I was watching this in December of 2017, the title of today's lecture came to me and I thought, the spooky, spiky, spindled sinonasal specters, and thought that was a catchy title to be able to discuss this broad group of spindle cell sinonasal tract tumors. So I'd like to give you a selection of these lesions, an emphasis on a practical approach to them and which particular histologic features can be used, as well as applying a pertinent immunohistochemical battery to them to be able to get to the correct diagnosis and how to integrate that with special studies. So again, I always like to start off with a case, a 52-year-old female with a long history of sinusitis. This is, of course, not the patient, although who would not mind having her as a patient? Here you can see a diagrammatic representation from the imaging to demonstrate the neoplastic or lesional tissue in this patient. So let's go and drive this case, because as again, I usually like to be able to drive one of these and show what it is that we see histologically. Multiple different fragments of tissue easily identified throughout. Let me go down to this space here, because again, seeing the bone that is present, and you can see that there's lots of bony interstices here, and within each of these bony interstices, you can see a spindled cell proliferation that seems to be destroying the bone as it has invaded out in between this. So at least the notion of dealing with some sort of neoplasm as opposed to an infectious or reactive lesion certainly comes to mind. Let's go and look at now the rest of the background here, a slightly different location. I think that you can see there are fairly sizable vessels within it with this very well-developed spindle cell neoplastic proliferation. Somewhat monotonous, right? I mean, if I went to super high power for a moment, I think you can see that these neoplastic cells are all quite monotonously similar one to another, set in a background of a rich fibrovascular stroma. However, I don't see any accentuation around vessels. The vessels don't seem to be particularly large. I don't see any increased mitotic activity in this field, but here I do see areas of epithelium. And in fact, as you look at the epithelium, it seems to be pulled down and then expands down into this region. And so the question at this point is, are these areas of epithelial islands deep within the tumor actually part of the tumor, or is it just a captured phenomenon and perhaps it is separate? So this is always a consideration when you look at these neoplasms to try and come up with what you may feel to be the correct diagnosis in this example. So when I think about spindle cell lesions of the head and neck and the sinonasal tract specifically, there's quite a daunting list, as you can tell from this overall grouping of them. And I'm going to discuss several of these lesions going through the rest of the presentation here, but just recognize that there really are a remarkable number of different neoplasms that are incorporated within this differential. The immunophenotypic profile, again, should be done on a panel approach basis in order to not lose out on the correct diagnosis or potentially miss the correct diagnosis because you have not done a sufficient number of markers. So you can tell that from this particular panel of 8 immunohistochemical studies, you can certainly narrow down the focus. And in fact, with the first 4, you really have quite a remarkable overlap still, but you're able to get a variation between which studies are positive and negative in order to be able to make a meaningful interpretation, or at least order some additional studies if you feel that they may be necessary. So an algorithmic approach is always helpful with these things, because if you have a good algorithm, you're not going to have missed something and you will actually work through it in a logical and progressive fashion. You won't have an excess number of immunophenotypic evaluations performed, and therefore will be able to keep the price of the evaluation down as well. So with that in mind, you know, again, a pancytokeratin has got to be included as kind of the major point focus in order to be able to separate between these major groups of lesions. And especially here, when I think about the pan-cytokeratin helping to kind of say, when it's positive versus negative, what's your overall differential in that setting? So let's start off with the positive, and spindle squamous cell carcinoma, again, is going to be the lesion that must be considered. So whenever you talk about the head and neck space as a whole, and certainly mucosal sites, squamous cell carcinoma has got to be considered. You know, it makes up nearly 85% of all of the neoplasms in this location. And so you must think about it, and given the spindle cell context of spindle squamous cell carcinoma. It's a relatively common variant within the head and neck space, and especially in the sinonasal tract. It's probably a little bit more common both in the larynx as well as in the oral cavity, but still in the sinonasal tract, you're likely to see it. Again, in an older age group, with the majority of patients being men. So when you have a case like this, it's probably quite easy to at least consider the interpretation, because you have an overlying squamous epithelium that is remarkably atypical. It shows clear evidence of pleomorphism and a full thickness epithelial dysplasia that then gently and mixes in an imperceptible fashion with the spindle cell population in the underlying stroma. But you can tell that there is remarkable pleomorphism here, and similarly here, with these cells just dropping off and expanding into the stroma. However, in an area like this, where you don't have a region of transformation or transition, a spindle cell morphology is a little bit more difficult here, perhaps giving you a more storiform to fascicular architecture, and therefore may not be as easy to suggest that this could be a spindle cell or sarcomatoid squamous cell carcinoma. Areas like this, when you have a hypocellular proliferation, are the most difficult to recognize, because even though there are isolated cells like this that can tell you something is probably wrong, and why is there, you know, this remarkable atypia just in isolated presence, but that is sometimes very, very difficult, especially if you're dealing with a frozen section, to be able to reach a correct interpretation. Generally, mitotic figures are quite easy to identify. Here I'm highlighting, 5 or 6 different mitoses, including atypical forms. And when you see them like this, they certainly will help you to reach the correct interpretation. Here is an AE1, AE3, very strongly and diffusely reactive in this neoplastic proliferation. Here is an example of the P40, and I'm just going to use those two just to highlight what you're able to see within this tumor category. So as you can see from the pan-cytokeratin reactivity, if you have a positive result, you kind of dump out all of the rest of these lesions. But just remember that squamous cell carcinoma is still present on the negative side. So you will notice I have SCC present out here with a negative reactivity pattern. And this is one of the important things to remember about spindle squamous cell carcinoma, is about 30% of cases will lack immunophenotypic reactivity with any epithelial markers. And this can be the pan-cytokeratin, AE1, AE3, even Oscar, and of course, P63, P40, CK56 are all going to be negative in this case as well. Interestingly, those that are completely negative tend to have a better overall response to radiation therapy and therefore have a better overall outcome. So in fact, if you're doing an immunophenotypic evaluation and do identify a negative squamous cell carcinoma for any of the epithelial markers, you're actually helping the patient in getting a better overall prognosis than what they would have otherwise. But it is still a lesion that you must consider in your differential with every one of these lesions. Well, I'm highlighting just a few of the other immunomarkers that can be seen beyond the CK pan, but just recognize that it is not always going to be positive. As you know, there are reporting protocols that are available. The ICCR is now a global presentation of this type of data, where it is a free-to-use histopathology reporting guide for each one of the major anatomic sites within the head and neck, as well as the endocrine organ systems. Clearly, all of the other systems are also included, but just as we're speaking about it here as it relates to the head and neck. Now, I would be remiss if I did not include the newly recognized TFCP2-rearranged Rhabdomyosarcoma. As you know, this is a high-grade rhabdomyosarcoma that is characterized by the TFCP2 fusion to either ESWR1 or FUS. And interestingly, the majority of these tumors occur in young patients, and also they specifically arise within bone and the craniofacial bones especially. So mandible and maxilla with growth then into either the sinonasal tract or the oral cavity can certainly be seen. And so it is unusual to have this kind of biphasic presentation of a spindled and epithelioid appearance of fascicles with very scant stroma. And then, either an epithelial, spindled, or round cell morphology can be seen with a very, very kind of monotonous appearance because, again, it is a rearranged rhabdomyosarcoma category. As you will notice, I'm putting in AE1, AE3, as well as the desmin, of course, being positive, but then MyoD1, myogenin are also seen, as is ALK. So the reason why this is so frequently missed as a diagnosis is because, unfortunately, people just do not think about it. They think it's going to be a squamous cell carcinoma, do the AE1, AE3, do not do any other markers, and call it a spindle squamous cell carcinoma. So here you will notice a single high-power field of one of these cases. And I will tell you, if I look at this, it doesn't take much imagination to say, well, is that surface epithelium actually blending with this adjacent tumor? It seems to be kind of dropping off in some areas. And so could this be a spindle squamous cell carcinoma? A bit more of a rhabdoid or plasmacytoid appearance is seen over here, with a little bit more of a plasmacytoid appearance in this example here. But here it's a very epithelioid overall growth pattern, seems to be somewhat monotonous, where all of the neoplastic cells, again, have a similar quality one to another, but presenting both an epithelioid as well as a spindle cell architectural appearance. So let's do a CK pan, AE1, AE3 in this case. You will notice a very strong and diffuse reaction, almost even in a Golgi type distribution or paranuclear distribution. And if that's the only stain you did, you're going to call it a squamous cell carcinoma. So the reason for doing a panel type approach is that you would have the myogenin, MyoD1 or desmin positivity, as well as ALK being present in most of these tumors. So again, if you aren't doing a panel approach, you're definitely going to miss this tumor, and the management of a rhabdomyosarcoma is going to be different than a squamous cell carcinoma. And of course, with the caveat that many of these cases are developing in younger patients. So just to highlight again that with that pan-cytokeratin and desmin being reactive, rhabdomyosarcoma is certainly going to be considered if you go down the pan-cytokeratin pathway. But if you go with the negative pathway, of course, you can still get to rhabdomyosarcoma as well, with the desmin and smooth muscle actin and some other marker types being positive. So the rhabdomyosarcoma is definitely a category that needs to be considered within the sinonasal tract, even if it is not specifically related to the unique profile suggested here. Okay, let's gray out the pan-cytokeratin side of the house for the moment. Consider that it is probably going to be negative, and then you have a whole host of different antibodies that can be used with kind of a algorithmic approach to get to your diagnosis based on staining for S100 and then smooth muscle actin or HMB45, desmin, SOX10, etc. So let's first talk about glow angiopericytoma. So this is a tumor that demonstrates perivascular myeloid phenotype, much more common in the older decades of life. Usually there is a unilateral nasal mass, and recurrence is seen in about 18% of patients. It tends to be unencapsulated and below an intact surface epithelium with a Grentz zone of separation. And then this diffuse pattern that will efface the adjacent structures, sometimes surrounding them, but generally effacing them, with a storiform whorled or palisaded architectural appearance and a very richly vascularized appearance. So this staghorn or antler-like configuration of large patulous spaces is very characteristic for the tumor, with a prominent peritheliomatous hyalinization. And I will say that that peritheliomatous hyalinization is one of the tip-offs for me of this particular diagnosis. So you will notice an intact surface epithelium over here. It is a respiratory type epithelium with this nondescript proliferation with very large and patulous vessels easily identified. The spindled morphology can be in a fascicular architecture, as you see here, and certainly suggests to you that a variety of different fascicular tumor categories should at least be considered. However, when you have these areas of peritheliomatous hyalinization, the diagnosis narrows very, very significantly, because that pattern is not seen very frequently in any of the other neoplastic considerations for this differential. Here is another example of that very prominent peritheliomatous hyalinization. It's usually a closely packed syncytium, so there's no separation between the cells from one to another. Vesicular to hyperchromatic nuclei, mild pleomorphism, extravasated erythrocytes, mast cells, and eosinophils are quite prominent. And then occasionally you may have giant cells or fat cells. So when I look at this, it's a very monotonous population. Again, this is related specifically to the molecular identification that can be seen in this tumor related to CTNNB1. But it is highlighting also the fact that you have lots of mast cells and eosinophils. Well, ironically, the mast cells are going to be positive with CD117. I think, as you know, the CD117 was kind of the antibody of the year, and everyone did CD117 on everything. So, of course, I had done it on the sinonasal glomerulonephritis category as well, and it is a nice marker of mast cells, which give you a nice internal control. However, the actins are going to be positive. There's a strong nuclear beta-catenin, and you may have variability with the CD34. The reason why I say that is it's very specifically related to which particular antibody you use as to whether the CD34 is positive or negative. Generally, it is negative if you're using the Q-bend monoclonal antibody. And then, as you know, the CTNNB1 gene encodes for beta-catenin, and the mutations are constitutively active of beta-catenin, which results in nuclear accumulation. And so it's a nuclear reactivity pattern with beta-catenin rather than the membranous type that you can see otherwise. So here you will notice CD34 highlighting the vessels, of course, but non-reactive in the neoplastic cells. And here is a very strong and diffuse smooth muscle actin, as well as a nuclear reactivity with beta-catenin. So again, they are very helpful findings in aggregate together in order to be able to reach this particular interpretation. So if you're following through with the profile, you'll see there really is only one way to get to glomerulonephritis. There isn't really much in the way of other things that come into mind with that particular differential, and just recognize that smooth muscle actin and nuclear beta-catenin are going to be the most helpful findings for that tumor, recognizing, again, as you can see with the green, that there are other tumor categories that are going to have reactivity with those markers as well. And if you don't do a panel approach, you may not reach the correct interpretation. Solitary fibrous tumor is a fusion gene-associated tumor of fibroblastic phenotype that shows a very characteristic branching vascular type appearance. And in fact, you know, the old terminology of hemangiopericystoma has certainly been used and is now no longer in vogue for this tumor category. Tends to be variably cellular, haphazard architecture, and of course the stellate and staghorn-like vessels are very characteristic for it. With nuclear, STAT6 reactivity is probably the most helpful finding in this neoplasm, while of course CD34, BCL2, and CD99 have also been reported. So if you don't have STAT6 available, certainly doing any of the others would be of help. And when it's included in a panel approach would be a way to reach the correct interpretation. Recognize that the STAT6 is actually an example of the NAB2 STAT6 fusion that seems to be quite specific, at least at this point, for this tumor. Polypoid type appearance to it, you will notice multiple different aggregates of the neoplastic cells, quite cellular, so it usually has a very blue overall appearance. Recognize that surface ulceration and denudation is common in the sinonasal tract or the oral cavity or even the larynx, and so you may have mitotic figures immediately below the areas of tumor ulceration. This should not be an area where you're going to try and count mitotic figures. As you know, there's a risk stratification for solitary fibrous tumor as a whole, and I would definitely not recommend counting mitoses so close to an area of denudation. Here is a more characteristic area with abundant areas of keloid-like collagen deposition that kind of overshadow the fibroblastic type proliferation in the background. But when you go up to high power, it has this very ropey collagen type appearance, which is in fact quite refractile. So if you drop the substage condenser, you would see that type of refractility in these neoplastic cells. So again, I've suggested that the STAT6 is super strong and positive in this neoplasm, and therefore if you think about what you would get with the various other immunophenotypic markers in your panel, the CD34 or STAT6 is really one of the most helpful in reaching this particular interpretation. And so you will see that STAT6 is part of that 8-panel approach. And the reason for this is it's the only tumor where solitary fibrous tumor is going to be positively identified without any overlap with anything else. So I do find it to be a very helpful marker. And I think now it's so ubiquitously commercially available, it's easy to include in your armamentarium. So melanoma, well, melanocytes are distributed throughout the upper aerodigestive tract and the oral cavity. There is a inducibility factor to it, so pre-existing melanosis can certainly be seen, although it doesn't really convert into the development of a melanoma. But be aware that about 4% of head and neck melanomas are mucosal in origin. And when that occurs, the oral cavity and sinonasal tract are the most common mucosal locations. So sunlight is a presumed non-factor. However, people lie out at the beach and the sun is going to go up the nose. And of course, if you're in a tanning booth, it's also going to go up the nose. So I don't know that it's actually entirely excluded as a potential factor. But for those of us in the laboratory industries, formaldehyde is an etiologic factor. It's usually much more common in painters and furniture or cabinet makers, but definitely pathologists and laboratory workers are at increased risk of developing the disease as well, as are those who live in southern latitudes. Mucosal melanoma occurs in equal sex distribution, which is a little bit different than you see from the cutaneous counterparts. And the same thing, it is a much older age range at initial presentation than it is for cutaneous melanomas. So there are some very different factors about how this particular disease presents. Melanoria, or black, cold-flecked, brown-flecked nasal discharge, is not a common finding, but certainly if it is seen, is very helpful in reaching the correct interpretation. The tumors tend to be quite sizable. So in other words, they're polypoid and fleshy. They tend to destroy the local area, and a dark tumor would suggest melanin pigmentation. But because ulceration is so frequently present, it makes the interpretation of either a Breslow's thickness or a Clark's level almost meaningless. So there's no point in doing it. There are multiple fragments. You don't know which end is going to be up or down, and therefore trying to measure from one edge to the other. You don't have the same landmarks within the stroma that you do in the cutaneous sites, and therefore this is really not something that should be meaningfully interpreted and is in fact not included in the staging system. So the radiographic finding, again, a large destructive mass, polypoid lesion coming off the nasal septum in this case, and when you look at the septum, it's a very, very darkly pigmented tumor, so that would help with the interpretation. And you can see on the gross it actually has destroyed into the cartilage and the bone as a neoplastic lesion. So if junctional activity is present or there's pagetoid spread present, it certainly helps to define a primary tumor, but just be aware that that is not always seen. And of course, there can be surface ulceration or erosion, and that would remove that particular interpretation. As you know, it's a very wide histologic spectrum for mucosal melanoma, and in fact, we sometimes use the word protean. And so I thought, well, let's put in Proteus here, the Greek god of change, presenting in multiple different forms. And this is a view from the Istanbul Archaeological Museum of a creature that has taken on multiple different appearances. And so that is exactly what you see with mucosal melanoma. Peritheliomatosis is quite distinctive, but an epithelioid solid fascicular storiform, papillary and alveolar patterns can all be seen. So here you will notice the neoplastic cells in the overlying surface epithelium and then dropping off into the stromal component. A nice neoplastic cell present here, right at the junction in a metaplastic squamous epithelium of the nasal cavity. Clearly, the pigment is easily identified here, and so melanin pigment would help you with your overall interpretation. However, if you had a case like this that is a bit more spindled to epithelioid in its architecture without any obvious pigmentation, it then becomes a little bit more challenging. An example like this, where there is a peritheliomatous distribution, again, wrapping around the vessels, but here you can see pigmentation is present in some of the neoplastic cells, and so that would be a tip-off to the underlying diagnosis. When you see an area like this with these elongated nuclei and scant cytoplasm almost presenting as a syncytial architecture, the notion of a melanoma may be quite difficult to reach. However, you will notice that there are actually quite prominent nucleoli. And so whenever I see very, very prominent nucleoli or intranuclear cytoplasmic inclusions in a spindle cell lesion, my index of suspicion of a melanoma is at least raised in that particular setting. And again, here you can see a super high power of the prominent nucleoli. So if you think about all of the melanocytic markers that are out there, SOX10 and S100, HMB45, tyrosinase, melan-A, the new kid on the block, PRAME, preferentially antibody expressed in melanoma, certainly is something to consider, although PRAME is not only positive in melanoma, it is positive in other things as well. And as you can expect, there's quite a bit of lineage infidelity and anomalous immunoreactivity, and so that can be quite difficult with some of these markers to know what you're dealing with. So in general, having more than one marker for a mucosal melanoma is my usual practice. Recognizing also that in the sinonasal tract and mucosal melanoma sites in general, NRAS and KIT mutation or amplifications are much more commonly identified than BRAF, since BRAF tends to be seen more frequently in cutaneous melanoma. So part of the reason I say this at this juncture is many times the clinician will hear melanoma, and of course their reflex is to do molecular testing, and they'll ask for BRAF. And you need to tell them, are you sure that you want BRAF in this tumor, because it's a mucosal tumor and probably is not going to be positive, so you're not going to be able to use a BRAF-based immunotherapy. So it is an important thing to recognize, especially when you're in tumor boards, to be able to say that type of information. So here is the SOX10. I think it's a very nice, strong, diffuse nuclear reaction. Here is an example of the S100 in this spindle cell population, while an example of HMB45 in that same spindle cell population. And then finally showing you an example of PRAME that is a nuclear reaction in the spindled neoplastic cells of this spindle cell melanoma of the sinonasal tract. So there is a wide armamentarium of various antibodies that can be performed. And so you can see, you can actually get to melanoma as a diagnosis through both positive and negative S100, and then depending upon which additional study may have been performed, you will finally reach that particular interpretation. There is also a reporting guide put out by the ICCR for the mucosal melanomas of the head and neck. And so if you ever had any question about which things need to be included, it certainly is an easy thing to be able to download and look at to make sure that your reporting is accurate and correct. You know, the malignant peripheral nerve sheath tumor is always a challenging lesion in the sinonasal tract. It's not a common tumor in that location. Recognize that it's usually sporadic, but of course can be seen both in the post-irradiation as well as in the neurofibromatosis or NF1 setting. Many of them will develop, in fact, in the head and neck space. So even though it only accounts for about 5% of all soft tissue sarcomas, about 20% of them occur in the head and neck area. As you can tell, it is at an older decade initially, except if it is NF1 associated, then it tends to occur at a younger group. A fascicular architecture of these long sweeping or herringbone type appearances are quite frequent for malignant peripheral nerve sheath tumor. They have kind of elongated or tapered nuclei with an irregular contour, and then of course that wavy or buckled appearance to the nucleus can be quite characteristic as well. Nuclear palisading can be seen, and sometimes even a peritheliomatous distribution will be identified with an MPNST as well. Recognize that rhabdomyosarcoma can occur within the setting of MPNST, and when that occurs, this was the previous name of malignant Triton tumor. As you can tell, about 60% of these develop within the setting of NF1, so the rhabdomyoblasts are usually a scattered finding rather than representing the dominant finding. And as you know, there is grading done for MPNST with low and high grades based on tumor necrosis, pleomorphism, and the presence or absence of mitotic figures. So here you can see buckled nuclei. You know, this is very fascicular architectural appearance. In fact, there is a vessel here in the center, and you can tell that the neoplastic cells have aggregated around it, but otherwise in a loosely fascicular architecture. An area of comedonecrosis is present in this neoplastic space as well, with these buckled nuclei that have a very long, pointy end to them, rather than being abrupt or cut off or squared off. So looking for that elongated and pointy nucleus is often quite helpful in coming up with the correct interpretation. As I already suggested, a peritheliomatous distribution can be quite helpful. As you can see, the neoplastic cells have arranged themselves around the vessel in a characteristic appearance. So as you know, the S100 protein is not usually expressed to any great degree or not. It's quite variable, therefore, and so the SOX10 or even EMA may be more helpful. But I do think that the most helpful finding nowadays is the H3K27Me3. This is a specific monoclonal antibody, and it's a lost stain in MPNST that helps with the interpretation. There is some grade association as well, although I'm not going to go into that at this particular time. So this is an example of the S100 protein. You can see that there is a very patchy, variable, weak reactivity with the nucleus and cytoplasm for S100 in this example. And then here is taken from the original publication with the H3K27Me3, where it is completely absent in the area of malignant transformation, while the underlying neurofibroma in this case happened to be positive for the nuclei. So it can be a very, very helpful finding as you use it in interpretation of MPNST. Again, you can reach the MPNST via a wide variety of different markers. So just recognize again that there is quite a variable immunoreactivity. You can even have smooth muscle actin reactivity in some of these tumors. And so just recognize that there is a broad differential consideration with the S100 positive tumor category throughout the spindle cell lesions of the upper aerodigestive tract. Leiomyosarcoma, as you are well aware, can be associated with irradiation or even cyclophosphamide exposure, EBV, immunocompromised patients. I will say that the EBV-associated spindle cell tumor has actually been kind of separated out now. There certainly are leiomyosarcomas that are EBV-associated, but I think the EBV-associated tumor group should probably be viewed as its own entity, especially when it is in the immunocompromised category. When that occurs, by the way, it does tend to be more frequently seen in younger patients than generally in leiomyosarcoma of other distribution. The oral cavity or sinonasal tract skin can certainly be affected. It's quite an aggressive neoplasm and, of course, quite stage dependent. So an interlacing fascicular to storiform bundles of these spindle-shaped cells are quite regularly seen at right angles is the most common that we like to see. And of course, when you do see that, at least consider this. Generally, they are centrally placed boxcar-shaped or blunt-ended cigar-shaped nuclei within the neoplastic cell with cytoplasm immediately surrounding it. Quite often, you will see a perinuclear vacuole or halo that can be quite helpful in reaching the diagnostic interpretation, often resulting in an indentation or concavity to the nucleus as it has pushed into that particular space. Mitotic activity is usually greater than 4. The reason I say this is there is a smooth muscle tumor of uncertain malignant potential or stump category within the sinonasal tract, and that is predicated on having a lower mitotic index. And so that is something at least to be considered within this tumor group. So here is an example of bone destruction. Again, destroying the bone is a frequent finding with any of these sarcomas that develop in the sinonasal tract. Mitotic figures are easy to identify and generally include atypical forms as well. So here you will notice that very characteristic cytoplasmic vacuole that appears immediately adjacent to the nucleus. I think you can tell that the nuclei are very boxy. They look cigar-shaped. They have a very well-defined border to them, and then immediately surrounded with this cytoplasmic vacuole, even here seen within a mitotic figure. So as you would expect, the actins are going to be positive, as is desmin, but I do think that the desmin is probably the most helpful in this example, since it is quite easy to interpret. So example of some smooth muscle actin as well as desmin in this neoplastic proliferation, helping to confirm the diagnosis of a leiomyosarcoma. So again, you can get to leiomyosarcoma through a variety of different antibody panels, recognizing again that you rarely have pan-cytokeratin reactive and variable S100 reactivity as well. So again, if you are not using a panel approach, it is possible that you would make an incorrect interpretation with some of these neoplasms. So synovial sarcoma rarely develops within the sinonasal tract, but remember again, about 10% develop within the head and neck space, often with a bimodal age range at initial presentation. So the younger patients as well as the older patients being seen, and usually the symptoms are quite non-specific. So from a macroscopic appearance, it may be quite pedunculated. And as you know, they are separated into monophasic and biphasic tumor categories. Monophasic is the most common in the head and neck, so that means you're unlikely to see the epithelioid component in the tumors. Suffice it to say, there is an epithelioid monophasic variant as well, but that's very, very uncommon in the sinonasal tract, and it is the monophasic spindle cell population that is more frequently seen. They're arranged in very dense, short fascicles, often associated with marbling, which just means that there's an alternating light and dark area, which I'll show you here in a moment. Spindle cells are usually indistinct cell borders, so they give a syncytial architectural appearance, quite often in a very rich hemangiopericytoma-like vascular pattern. And remember that mitotic figures can be seen, but are not usually greatly increased. Well, let me just say that I'm a vegetarian, so I didn't know what marbling was initially, and someone said, oh yes, this is what good fat is. If you're getting Kobe beef, it's gorgeously marbled, and that's alternating fat and muscle, and that is exactly what you see with a synovial sarcoma with a biphasic presentation. It has this characteristic marbling. I will say I've seen marbling with MPNST as well, so it's not specific, but on low power, that marbling appearance can be quite helpful in reaching the interpretation. So here I'm showing a monophasic variant. This is actually the surface epithelium, and I'm specifically including it here again because, you know, as I showed with the initial slide that I drove, and I'm going to talk about that diagnosis here in a few moments, whether this surface is actually at the surface or whether it's a little bit deeper down and being pulled in, or is it actually part of the neoplastic proliferation, can sometimes be remarkably challenging. Here is an example of that peripheral of the patulous vessels or staghorn type vessels that can be seen in synovial sarcoma, as well as several of the other neoplasms. So again, it is not a unique finding within the head and neck space. Here you will notice epithelioid type cells. So I think you can all see that these are quite epithelioid in their appearance, almost giving you a glandular type feel, while the rest of them are spindled in these fascicles. So this would be an example of a biphasic synovial sarcoma as an uncommon entity within the sinonasal tract area. So be aware that they will be reactive with epithelial markers. Of course, they will also be reactive with TLE1, and then S100, CD99, smooth muscle actin, BCL2 can be variably expressed within a synovial sarcoma as well. As you know, there is a very characteristic gene fusion with the SS18 and either fusing with SSX 1, 2, or 4 as an example of what you can see in that tumor. This is an example of that biphasic tumor I just demonstrated, where you can see that the epithelioid cells, as well as several of the spindle cells, are reactive with CK-pan. But in this example, there's a very strong TLE1 that is easily identified in the nucleus of these neoplastic cells. You should make sure that you're using the best clone available, otherwise you may have spurious reactivity. So again, using the pan-cytokeratin, I had said that you may not always have that and go to the opposite direction, which is why you can see that synovial sarcoma can actually be reached in a variety of different ways, incorporating the CK-pan as one of the markers that can be seen along with TLE1. The Fish-Baker part probe, specifically for SS18, is probably the best that can be used. And here you can see a very nice example in this illustration. Well, let me just discuss a couple of benign lesions, because angiofibroma certainly is a spindle cell lesion of the upper aerodigestive tract and exclusively in male patients. And this is genetically male patients. So boys and adolescent to young men will present with the tumor. And because it is a testosterone-dependent puberty-induced growth, it is something that you really are only going to see within the male patient category. The classic triad of nasal obstruction, a mass, and recurrent and spontaneous episodic epistaxis is very, very characteristic for the tumor. And as you look at this, you can see it is just a remarkably destructive lesion in many patients. So you should not look at this and say, oh, this is going to be a malignant tumor, when you recognize that some of these tumors can actually be quite remarkably large. In fact, for many of them, they will do angiography. And in this case, I'll demonstrate, I created a GIF from one of the angiograms. And as you can see with the injection of the material, you can really see that it fills out into that nasopharyngeal and posterior sinonasal tract area and is therefore able to help confirm the diagnosis and also allow them to use embolic material in order to be able to manage the possibility of bleeding. As I suggested from that imaging, the tumors can be remarkably sized. And here you can tell an example where you have the negative outlines of the turbinates in each of these cases, where the tumor has actually expanded and grown around them, compressing the underlying turbinate type tissue. So as you know, it's a submucosal proliferation of a very rich vascular component set within a fibrous connective tissue stroma. Multiple different size vessels are seen. So the variability of the vessel is actually the tip-off to the diagnosis, because you will have thin-walled and slit-like or staghorn vessels, capillaries, and then these very large patulous vessels, and very thick-walled vessels as well, all of them lacking an internal elastic lamina. And this is the reason why there is often remarkable bleeding, because there is nothing in the vessel wall to result in constriction and therefore closing off of the vessel. There are usually a wide variety of different background fibrous collagenized tissue. And because of that, depending upon the arc of development, there may be a lot more collagen deposition later on in the disease arc of development. Endothelial markers, of course, will be positive within the endothelial cells, but the stromal component will actually be positive with both androgen receptor as well as nuclear beta-catenin. So here you will notice a nice example of a wide variety of different vessels. I think the smooth muscle-walled vessels certainly stand out in this polypoid tumor. When you go up to higher power, though, you can see now multiple different vessel sizes, with ones that have absolutely no smooth muscle wall, very pad-like deposition of smooth muscle here, and then a very, very thick smooth muscle-walled vessel adjacent. Again, another highlighting of the various vessels that are seen within this tumor, and that is a tip-off to the underlying diagnostic entity or diagnostic category. Recognize that with time, you may have a remarkable deposition of collagenous tissue, here being deposited in a fibroblastic type distribution and giving you a keloid-like collagen deposition in some areas. Embolic material, again, can be seen, and here you can note the vessel is filled with the foreign material. So whenever I see this, at least an index of suspicion for a vascularized tumor should be considered. The other time you see this within the sinonasal tract area is quite often with solitary fibrous tumor, as that is another tumor category that tends to be quite vascular on imaging, and therefore they may try to reduce the amount of bleeding intraoperatively by doing pre-surgical embolization. Here is a strong nuclear beta-catenin in the neoplastic cells, which helps to confirm the diagnosis, as you will notice with this very strong androgen receptor. As I've already suggested, it is an androgen-dependent growth, and therefore AR is going to be strongly and diffusely positive in the neoplastic cells. You will notice that the lining endothelial cells within the vessel wall are obviously not reactive, since they are not considered to be necessarily part of the growth of the fibroblastic tissue. I must mention an antrochoanal polyp just for a moment. This is a tumor that arises within the maxillary sinus, pushes out through the choana, and then presents in a similar fashion, where you can see this very large polypoid lesion that can be a mimic on radiographic imaging for a angiofibroma. But when you look at the tissue, you will notice that there is no evidence of any sort of glandular or minor mucocerous glands, but instead you do have a spindled population with this edematous type background stroma that is often destroyed or undergoes degeneration. But when you look at the spindle cells, they can be quite remarkably atypical, as you will notice with this one here showing an intranuclear cytoplasmic inclusion. And these, of course, will be Desmond reactive, but will not be reactive with nuclear beta-catenin nor with a nuclear androgen receptor. Respiratory epithelial adenomatoid hamartoma is a non-neoplastic overgrowth, but it can have a spindle cell appearance, and of course is in the differential for the final lesion that I'm going to talk about in a few moments. But just be aware that it is devoid of any ectodermal or neuroectodermal elements, and it is not the same as a chondromesenchymal hamartoma, which is associated with the Dicer-1 syndrome. So it's a rare lesion, usually presenting with nasal obstruction, quite often high up in the orbits. Here you can see one involving the very high sinonasal tract. Quite frequently will be associated with a widening of the optic groove, as you can see in this example. So they tend to be dominated by a glandular proliferation, and they are widely and evenly spaced of medium-sized glands with a fibroblastic stroma between them. The glands are in direct continuity with the surface epithelium, and they invaginate down into the underlying submucosal tissues. The glands are surrounded by this very, very characteristic thick eosinophilic basement membrane type material. And that is, of course, again, the tip off to the underlying diagnosis, because that is quite characteristic for this particular hamartoma. So here on low power, you can see multiple glands. There is a variation in the size, but you can see that there's kind of an evenness to their distribution. You will notice these are the uninvolved minor mucocerous glands that are not the surface epithelium that has dropped off to create these undulating appearances. So it gives kind of a cerebriform appearance when you look at the cut surface. Another example here, and I think you can already tell the very thick basement membrane here that I'm going to talk about in a moment, but a very well-developed mucinous type epithelium that is present within the lesion. Another example here, highlighting the very, very well-developed area of a thickened basement membrane, giving you that very bright eosinophilic appearance around each of the glandular elements coming down from the surface. Here is another example with inflammatory cells, just to show that sometimes it can be a little bit more subtle, but still that very, very thick hyalinized basement membrane can certainly be easily identified. And then, of course, when you look at the central component, respiratory epithelium is present. You may have this kind of tufting or serration that develops within the central part of it, showing a very nice ciliated respiratory epithelium. As you know, the vast majority of things that have cilia in them are benign. Of course, there are always exceptions, and there are some adenocarcinomas in the sinonasal tract that may have cilia, including some of the mucoepidermoid carcinoma category. Immunohistochemistry tends not to be of very much value in this case, because you still have an intact P63 layer surrounding it, and so that doesn't really help in separating it from other lesions in the differential. However, let's now move on to biphenotypic sinonasal sarcoma. So this is a very specific low-grade spindle cell sarcoma with a distinctive histology as well as immunohistochemistry, and most frequently characterized by a PAX3 mammal3 gene fusion. And so you may say, well, you know, where did this come from? Well, of course, it came from all of the tumors that I've just been discussing, because once it was identified and people went back into their case, you will notice that now this is the correct diagnosis for the case that I drove, where there really is a very, very characteristic appearance for this tumor. You can tell that the previous name was low-grade sinonasal sarcoma with neural and myogenic features, a huge mouthful. So biphenotypic sinonasal sarcoma is the term that has been utilized by the World Health Organization and now is what is used in general. So a cellular submucosal spindle cell proliferation, unencapsulated and infiltrative, usually involving bone as well. These elongated spindle cells are arranged in an intersecting to fascicular or herringbone type appearance with a very limited amount of collagenized stroma. There are usually very few mitoses, and the cells tend to be quite monotonous. However, there is this very striking proliferation of the epithelium that extends down as invaginations that is intimately associated with the neoplastic cells, and it can undergo squamous metaplasia or even oncocytic metaplasia. So sometimes it will even resemble a sinonasal papilloma. Now, let me just say immediately, the fact that you have this glandular component is not the reason why it is called biphenotypic. The biphenotypic relates to the fact that there is co-expression of S100 and smooth muscle actin in the neoplastic spindle cells. It has got nothing to do with this epithelial invagination. And so just be aware that the biphenotypic definitely is not related to this feature, even though it is a very characteristic finding. Recognize that rhabdomyoblastic differentiation can also be seen in some of these tumors, and in fact, it is recognized now in about 10% of them. And when that occurs, it actually does have an alternate fusion partner. So when I look at this, I can see that the surface is uninvolved. There's an area of separation, and then you get into this interlacing fascicular to storiform architecture of a spindle cell population. Here is that spindle cell population, and again, you can see that there is invagination of the surface epithelium, but sometimes it can be quite strikingly deep in what you see. And here you will notice bone invasion, and yet here is still this surface epithelium that has been dragged down into the neoplastic proliferation and is not part of it. But let me just tell you, if you get a limited biopsy of something like this, the notion of could this be an example of a synovial sarcoma or some other neoplasm with a biphasic presentation certainly does cross the mind as you're looking at these single high power field areas. Bone involvement is certainly present in many of the cases. I illustrated that in the slide that I drove at the beginning, but you can really tell how there is destructive involvement of the bone. It is often quite monotonous in its overall appearance, not much in the way of pleomorphism. And so again, whenever I have fusion-associated tumors, they tend to be much more monotonous than those that are driven by a wide diversity of various molecular pathways involved. Here again, you can see that nice fascicular architecture with an area of surface epithelium pulled in, and you'll notice even some of the glandular differentiation within it. And so that can sometimes be confusing as to what the underlying neoplasm may be. Here is an area of rhabdoid differentiation. You can see that there are strap-like cells present within this proliferation. They are not the dominant finding, but certainly they are easy to identify within this tumor, including areas of cross-striation. I think the most important consideration is that the staining may be focal, patchy, or diffuse. So no matter what, when you're doing the S100 and smooth muscle actin or muscle-specific actin, you have to have a very low threshold of interpretation for a positive result, because it may be in a very limited distribution. And with that in mind, if you have a core needle biopsy or a very limited sampling, that particular area of the tumor may not actually express S100 protein or smooth muscle actin, and therefore you could be led down a different pathway if you don't have the entire tumor to examine. Be aware that PAX3 as an immuno can be done on these cases, and nuclear beta-catenin is also seen within this category. You may have some variable reactivity with things like desmin or myogenin, even TLE1, because of course I've already suggested it can have anomalous immunoreactivity. So this is an example of diffuse S100 protein reactivity, while this is an example of a less diffuse and a little bit more patchy, in fact, raising the differential with a malignant peripheral nerve sheath tumor. Here is an area of smooth muscle actin reactivity in the neoplastic cells, a little bit more diffuse and strong in a different area of another tumor, just to highlight that there really is a remarkable diversity in the immunoreactivity that can be seen within this tumor category. Nuclear beta-catenin can be seen, but one of the important things is that SOX10 is not reactive in the tumor. So if you're doing a panel approach with the S100 and the SOX10 here you can see is nicely highlighting the myoepithelial cells of a minor mucocerus gland deep within the tumor, but is not actually present within the neoplastic cells. When there are areas of rhabdomyoblastic differentiation, desmin will be positive, as will myogenin or some of the other skeletal muscle markers. So just be aware that that certainly is something that can be co-expressed. And this is an example of PAX3. Well, yeah, I know, it's kind of a pathetic stain. I mean, it is positive in the nuclei, but it is a very difficult stain to get to work correctly. There are some commercial labs that will offer it, but just be aware it can be performed, but you really must know how to interpret the result. Having said that, you obviously can do a break apart fish probe, as you know that it is related specifically to PAX3 and mammal3. So you can actually do a PAX3 as the particular fish probe to be able to detect it. As I've already suggested, the mammal3 is seen in most of the spindle cell tumors, but when you have a FOXO1 or NCOA-A1, you may recognize that those are more frequently identified within rhabdomyosarcoma, and so those that show rhabdomyoblastic differentiation are those that have an alternate fusion partner. Local recurrence is quite common with the biphenotypic sinonasal sarcoma, but so far there are very, very isolated cases of metastatic disease or death from disease. So in general, it is an overall very good overall outcome for these tumors. And of course, it is included within the World Health Organization classification. So we go back to our immunophenotypic panel. And the reason I'm ending with this is I think you can see that biphenotypic sinonasal sarcoma, is shown here in red, really has a remarkable overlap with all of these others. And so there really is quite a diverse reactivity pattern within this tumor, and is one that needs to be considered carefully as you go through the spindle cell tumor category. Well, you may say, why did I put this in the order that I'm showing over here? Well, this is a really lame acronym, but if you take all of the first letters, it's BROS for my good lab practice. Well, what the devil is that supposed to mean? I'm not sure, but at least it is some way for you to be able to recognize that there is a wide variety of tumors considered within the world of spindle cell lesions of the sinonasal tract. I'll be very happy to answer any questions should you have any, and appreciate you taking the time to listen to this conference. Have a great day.